while going through the literature, they say in 50-60% of the cases there is sloughing of the skin where you inject. There is hyperpigmentation, there is severe pain you have described. But they say the sloughing and ulceration is quite common over the injection site.
And Fitzpatrick by Calbrine group, and another one in 2004 by an Indian group, and some 2-3 more in the US. They all reported transient pain, which was the most common, 100%. And sloughing, in fact, Fitzpatrick just reported 3 cases out of his series, and the rest didn't report really sloughing. They just reported erythema and irritation. And the sloughing was only if the needle entered epidermally, and you got like a Purdy Origins appearance, and then you knew you were on the wrong side. Otherwise, it was, all of them have said, intradermal to middermal is where the injection should specifically be, and you get a raised, slightly bleb-like lesion. But if you get bubbles, then you're in the wrong, and that causes a sloughing and necrosis.
Some of the pictures which you showed, they could have disappeared with time also, because your thing is not randomized.
Yes, absolutely. Yeah. So what they have said in a lot of these literatures which we study is the way a scar follows the history, natural history, is that at about 2 to 3 weeks, it's a little hypertrophic, erythematous, and raised, itchy. Then about at 1 month, it's flattens and softens, and any scar by 7 months usually fades and completely flattens. But in patients who either have a tendency or a hypertrophic scar, the purpose was, instead of waiting for the 7-month period, if we intervened early, then we would be able to get better, softer, scarless results, even in cases where there was severe trauma, as was seen in the child. I intervened only at 2 months because I was being cautious. But the literature, and even Fitzpatrick and all the people who have followed him after, have intervened as early as 4 to 6 weeks. I was cautious because we were trying 5FU in the periocular area. It is a very responsive area, but it is a thin skin, it's highly sensitive, and so I was more cautious about doing it and letting the scar take its natural course for 6 to 8 weeks, following which we did. Even the scar injection period, Dr. Gupta, was, most of the literature says 1 week, 2 weeks, or even 3 weeks. But we kept it at 6 weeks because we wanted to see a combination of the natural and the intralesional response.
That's perfectly all right. Which you showed, had keloid, suppose you showed, there was no proliferative phase at that time. There was no heat scar. So you mentioned that the procedure is helpful in proliferative phase only.
No, it has the maturation stage goes for like from 3 to 4 weeks to 3 to 4 months. So
your case was after 4 months, you said?
The keloid.
Keloid and the other first case.
The first case I didn't have a picture for. The cicatricial ectropia, yes, was the second case I actually tried Dr. Vacharani, and we said, okay, instead of trying steroids, we know this works in the literature, so let us try. When this person came, he was not keen on surgery, which is what I would have probably recommended him at that time. But we said, let's try this. And after 1 injection, he came back with such a dramatic response that we said, okay, we'll do one. After the second, I was actually encouraging him to go for a 3rd injection, but he really was not. He was very happy because he said, this is all I really wanted. Stage, which is very clearly mentioned by Fitzpatrick, that old scars, even if they may not have a dramatic response as young scars, they still flatten and soften significantly.
The same thing again, you mentioned that this is probably just the beginning of, we know about let's say, use of 5FU, but I think a more clearer answer can only come out if you kind of look at now that you have these results, to look at a prospective, comparative, maybe if not randomized, that's more difficult, but then at least a prospective, comparative data to look at, not only compare it with no intervention or other the gold standard that is known, or even what is the best timing of giving the injection and how much.
Very nice work. One is, if a wound is under some amount of tension, is there a chance that by putting 5FU, we are weakening the wound and possibly causing dehiscence? And secondly, what is the latest you would recommend the injection be used?
From the time of, I went in cautiously with that possibility that might be weakening the wound, and hence we did not, the earliest we had done was 6 weeks. But the more have done, gone a little closer to the 1 month mark when the scars are hypertrophic and well healed. I've realized that the response definitely, as mentioned in the literature, has been more dramatic, and the patients are responding and the scars are flattening much better. And instead of waiting for that proliferative and maturation phase where there is chances of the scar thickening, it doesn't even go to that phase. So maybe I would intervene at least at the end of 4 weeks. And that sort of takes care of the second question, but if I was a little cautious that I'm not very confident that the wound is completely healed, especially in diabetics, and the lady with the basal cell carcinoma excision was a diabetic, and hence for her I definitely waited for like a good 2 months before we injected.
Thank you.
Incidence of primary ankylosing glaucoma. I request Dr. Jayanta Kumar Das to present today.
My topic is on lead anthropometry and its correlation with high incidence of primary ankylosing glaucoma. We have no financial risk. Studies have found that Southeast Asian and Chinese population are more PSCG incorporated at this time. Why PSCG is so much more prevalent in our region, mainly Southeast Asia? One reason is that it was identified that Asians may anatomically more predisposed. But what is the reason? We don't know. Related with lots of variation amongst our population. One reason is that Asians may be anatomically predisposed to PSCG. In Asian eyes, the iris, and this is the still now is that from the glaucoma point of view, the iris pattern is only concerned. In some Asian population, there is a highest 3%, in some areas more than 14%, because India is the only country with lots of Mongol, Italian, and some others, maybe 2 factors. In compared to other Eastern and Africans, is 0.5% only. In Indian population-based studies, with prevalence of PSCG varies in different surveys. Those are staying in abroad and others. So there may be something inside. So those are same, in my picture, all are same group of patients, Mongolian patients, but lead is different and lead height is different. So this is the actually background in my mind. So there may be something in the lead, maybe. So there may be something. So purpose of our study, it is a study, we aim to identify any correlation between upper lead anthropometry and high incidence of ankylosing northeastern region. Is a case control prospective study was carried out from January 2011 to December 2012. In study group, patients all are above 40 years, and the same number of patients from control group, and the same age, same region, same enrollment criteria. The cases were identified directly by the investigators. Those are attending to our glaucoma department, and others are the rest of the from other diseases. Those are the criteria for enrollment. There's more than 40 years, axial length less than more than 22 in all the cases, and those are the performance in all other cases. And especially, we are taking contact gonioscopy in all the cases, and horizontal lead and palpable fissure height, lead distance, tarsal plate height, and axial length. This is a very, in other cases, first we can measure horizontal length, lead height, etc. Then, especially for to know the tarsal plate height, generally I prefer carry, but I heard and thus I take it and assess. Data collection was done by peer-to-peer tests to rule out our null hypothesis. In our results, in the study group, we include already 180, and in the control also 180. In age range, almost we try to maintain, and that's why it's 58.17 in years in case of age of control, and in other disease, and in control 57.86. Male female ratio 0.5 to 1 as is common. In a primary include is known factor. So, in our results, there's a bar diagram showing the horizontal length. What is the horizontal length of case and control? Is in cases is 27.93, which is standard deviation 1.25, and in control group 28.98. The same ethnicity, same group, same is and that the p value is very, very significant, is at a less than 0.01, which is 1% level of significance. Regarding the vertical height also, it is very, very significant, and it is 8.4 in a 8.4 in mean is the 8.4 in a case and 8.7 in control, and again that is very, very, very significant. And lead crease distance, of course, that is related to the tarsal plate height, and all are in a very, very significant. Of course, it is 0.05% less than, and still it is 1% level. And very important is the tarsal plate height. And as per our bar diagram showing that standard deviation is 0.9 and 0.7, which is very, very important. And in a case 7.77, and in case of a control is 8.67. Cases means those are already suffering from angle-cruiser trauma, or there is a history of PI. On discussion that South Asians are significantly high risk angle-cruiser trauma, but very few studies aim to elucidating that epidemiological factor responsible for higher incidence. In this study, we identified that correlation between upper lid anatomy with that other population. The significant people were 0.01, which is significant at 1% level in most of the cases, which is one of the key factor for high PSSG in Southeast Asia. Recent data also supported our studies, like, of course, those are in relation to the blepharoplasty, more subcutaneous and subauricular fat, which is a pretarsal fat component, double eyelid, single eyelid source fashion, a pretarsal fat pad is identified in Asian single eyelid. Ophthalmic text, of course, is mentioned that 10 to 12 mm is the tarsal plate height in upper and in lower 5 mm. But in our part, we know is the factor is tarsal plate height is less than 10. In our that case group is significantly less, but in control slightly, but still less. Is a comprehensive analysis of it in our study will help future researchers for this. We can provide some data for future researchers. So, with our study, I want to conclude that less tarsal plate height, along with less horizontal length, less vertical height, and low lid crease distance are significantly related with a high incidence of PUCG in our study. We strongly recommended to consider these parameters as a major contributing factor for a high incidence of PUCG in our region. Thank you, sir. Those are the selective references.
The whole of all the parameters.
No, all
And
parameters.
the biometric study of the whole globe.
No. Because our mind is already established, so then there is no need for the others. Because our glaucoma department is already doing those things. Gonioscopy, there are other depth, etc. But my concern as a plastic surgeon, is there any relation to see that those are the vulnerable patients? In all other cases, gonioscopy may not be available in some rural areas, or that the point is that if they can understand less tarsal plate is one of the features, they can go for a gonioscopy. In some government setup, there's a huge crowd. It is not possible for each and every person to go for gonioscopy. So, from oculoplastic point of view, this is our observation. This is a oculoplastic point of view, not a glaucoma point of view. Glaucoma point of view is established, but why angle? Why angle is narrow? Why? There may be some pressure effect on the lid.
Yeah, Dr. Das, but then there are things like, was your study power rated to the angle closure, finding these patients at risk? Those are questions. Anyway, we're short of time. We'll thank you for your presentation, and we'll go to the last one.
Itala.
Now, when trying to find out one unexpected angle prognosis, there are no financial disclosures. First, for the introduction, neurofibromatosis is a multisystem genetic disorder that commonly is associated with the cutaneous neurological and orthopedic manifestations. It was the Dr. Riccardi in 1973 who first classified neurofibromatosis into the 5 types. The neurofibromatosis 1, which is also called as von Recklinghausen's neurofibromatosis, type 2, which is characterized by the bilateral acoustic schwannomas, type 3, it is a mixed variety which comprises of the characteristics of NF1 and NF2, type 4, which is a variant associated with the various symptoms, and type 5, which is of late onset. But the types, type 1, type 2 and type 3, which is also called as the histology criteria for the NF1 and NF2. Now, we present a case of 28-year-old male who presented with the abnormal right eye prominence over 1 year of period associated with the right-sided frontal headache. He also mentioned difficulty in chewing on the right side. He also gave the history of feet sensation radiating from his wrist to numbness of his right leg with a minimal weakness, and there was no history of fever or loss of weight or appetite. On ophthalmic examination, best corrected visual acuity in both ISO 66 and N6. The intraocular pressure was 49-17 mm of Hg in right and left eye respectively. The left eye anterior segment examination was within normal limits, but in the right eye, proptosis was mentioned along with the restriction of the extraocular movement in the levo and dextrodepression. On proptosis evaluation, the axial proptosis was noted, and the distance from the lateral canthus to apex of the cornea, it was about 8 mm, which was noted. On palpation, the rectopunction test was found to be positive, and finger insinuation test was negative in all 4 quadrants. On auscultation, no bruit was felt. The neurological examination evaluation was done, and tests for all cranial nerves were normal except right-sided fifth cranial nerve and right-sided monoparesis. There was the systemic evaluation was also done, and no significant systemic involvement was seen. To summarize, axial proptosis of 8 mm in the right eye was noted. Lead signs suggestive of tiara were absent. Mild extraocular muscle movement restriction in dextro and levo depression was seen. Rest anterior and posterior segment examination was within normal limits. There was loss of sensation over cornea and right half of the face and weakness of the right-sided masticating muscles. From above finding, a comprehensive diagnosis of intracorneal benign mass compressing third and fifth cranial nerve was made, and a battery of special investigation was done. Color vision and central fields were within normal limits. Diplopia and hair starting was done, and which excluded the involvement of the third nerve, and MRI brain was done. The MRI brain on axial view showed the well-defined fusiform hypointense solid mass in the right intracorneal space associated with the similar well-defined hypointense dumbbell-shaped mass which was originating in the Merkel's cave, presenting in the medial cranial fossa, which was extending into the posterior cranial fossa. On the sagittal view on the T2 stage, a hyperintense well-defined mass was noted in the infratemporal fossa, which was present around the distribution of the maxillary nerve. So, the MRI brain revealed the involvement of fifth cranial nerve, ganglion and its branches. The case was discussed with neurosurgeon, and patient was advised to undergo a transnasal endoscopic biopsy and full body MRI. On the histopathology, acellular Antony A area and paucicellular Antony B area and the myxoid stroma was noted, which was highly suggestive of the schwannoma. A full body MRI revealed similar masses along the course of obturator internus nerve and the nutrient foramen of the femur. So, with the consultation and on the basis of above findings, a diagnosis of presumed schwannomatosis, also called as neurofibromatosis type 3, involving cranial nerve and peripheral nerves of the pelvis was made. So, coming to the discussion part, there are 3 major categories of peripheral nerve tumors, which includes neurofibroma, schwannoma, and malignant peripheral nerve sheath tumors. Schwannoma, it usually occurs in isolation, but if it is present in multiple number, it is suggestive of neurofibromatosis 3. It is a benign, slowly growing, encapsulated homogeneous mass which consists of only Schwann cells. It is usually present outside the nerve. It may push it aside and press against the adjacent structure, causing the damage. So, if the schwannoma can present in isolation, if it is occurring in multiple number, and if it is associated with the vestibular schwannoma, we can call it as a neurofibromatosis 2. But if it is occurring in multiple number, and if it is not associated with the vestibular schwannomas, we can call this as a multiple schwannomatosis or neurofibromatosis 3. So now there are well-established criteria for the diagnosis of the neurofibromatosis 3. But our case, we lag behind with the mutational analysis. So our patient fits into the criteria of presumed diagnosis of the NF3. We can find out the 3 or more non-intradermal schwannomas, and we have one with the histologic confirmation. There was no evidence of vestibular tumor on high-quality MRI scan, and no symptoms of ethno dysfunction was made. So in summary, orbital schwannomas consist of less than 1% of the orbital tumors. Usually it occurs in first division of the trigeminal nerve. Symptoms depend upon the location of mass. Patient may present with the intermittent diplopia, localized mass, proptosis, anesthesia of the involved segment and disfigurement. Complete mass excision of the systematic schwannomas is the treatment of choice, but recurrences has been reported in the 2 cases. why this case? The axon proptosis is an unusual presentation of the schwannomatosis. Thorough system evaluation is needed, and a triad of neuroimaging, histopathology.
The time is over, please. We are already running short of time. Please stop.
Thank you, Dr. Dipti, for an excellent presentation. With this, we come to the end of the session of free papers. Thank you, and with this, we hand over the session to the next.
It's better we know all are here. Ramesh Chandra.
Dr. Ramesh is there.
Yeah.
Dr.
Savri
Savri is
Desai,
here.
Rashmi Shukla.
Yes. Savri is here. Then Shashi Jain. Aditi. Okay, fine.
You made note of that? Oh, okay. You are right.
The next one is Vaibhav.
Is he here?
And Dr. Bharti Pawar.
Bhargavi. Yes.
Bhargavi. Sorry.
Saurabh. Presenting author is Aarti. Yes. Dr. Aditi. Yes.
Aditi Pujari.
And Kasturi is here.
Transfer in the management of lag of thalamus, Dr. Ramesh Chandra Gupta.
My paper is on silicon sling assisted impulse transfer in management of lag of thalamus. This is the technique which usually we use to use the facial data for doing impulse transfer. Now we have tried the silicon sling for doing this procedure. I have no functional disclosure to make. As you know that one of the very common clinical condition is facial paralysis, which we actually encounter in our practice, and it's got a lot of devastating functional and cosmetic problems, which leads to atrophy on the leg of thalamus, as you know, and this can lead to very severe conditions, as we all are aware. These are the various causes, and of course, we have to restore the symmetry and the functional integrity of the eyelid, which is, of course, it is our duty also, and it should be rewarding to the patient also. Then we have various procedures which for this particular condition, as we know that in the form of static and dynamic. In static procedures, we have various procedures like dorsography, the peripheral spring, and the lid loading. Lid loading is, I think, is becoming commoner in oculoplastics field, and the dynamic is only one, that is the temporalis muscle transfer. So various techniques have been described for this, as we already know by the literature, and these other procedures like peripheral spring, they are technically difficult, and there is high risk of exclusion of these various springs. Then dorsography has a poor cosmesis and of course decreased peripheral vision, that we all know, and of course it is least acceptable by the patient. Then lid loading is of course a good procedure, but it has got its own limitation of cost and body extrusion, as we all know. Then the ideal procedure should be the dynamic, the avoiding bulk of muscle in the temporal fascia, temporal area, as we all know that we are aware because of gas masses, and less extensive surgery. Technically it is easy because when we used to use the temporal fascia or the fascia lata, we used to have a very extensive surgery. Then just we tried in about 12 patients so far, but just I'm showing on just focusing on the technique how we actually do. So this is the patient in which we have performed the first case, and just after operation, this was the result. This is after a week, and that's why we have modified it to like this. I'll show a video that how we are going to this technique.
Ramesh, be a little quick because it's a beautiful paper. We don't want you to waste time.
now we are giving a incision. So after giving incision and exposing the temporalis muscle, this is just a body of the temporalis muscle in which we are passing the silicone, as we know that it is available with the needles.
There is an incision you made?
Yeah, just in one line which is drawn from the tragus to the lateral canal. And then we are passing this sling from there. See, from here we are just coming to pass it just subcutaneously, and we are coming each string to the each lid margin, as we are doing in the ptosis. Same way. Then we are coming to the medial canthus and exposing the medial vertebral ligament. And after that, we are passing each of the sling behind the superior one from the inferior side and from inferior one from the superior side, and just put a sleeve as we are putting in the ptosis and undermining it, and just the tightening of that is the experience, and that is the only thing which we have to adjust, that how much tightening actually we want to ensure that there should not be exposure post-operative period. And if there is some torn during this procedure, because of course this may be possible when you are passing the sutures from inferior to superior and inferior to superior, then you have to ensure it just anchoring with the periosteum. And after that, of course, we close the.
Time is up, Ramesh. Anything you want to summarize?
Just.
Sure. Quickly, because it's a great paper, you should be a little fast.
Okay, say that means that this we have done so far 12 cases, and they all are doing very well. And of course, this is published, already accepted in the AIOC. I think it will be published soon. And I think these are the post-operative results. And of course, we have
Let's go back to the post-op results quickly.
This is after 3 months. So this is a valuable technique, and I suggest and recommend that this technique should be popularized. Thank you so much.
Excellent.
Thank you, Dr. Ramesh. Just one question. What is the end point of the tightening?
If it is preoperative lymphomas is there, and how much ectropion is present in the lower lid. That is, these are two criteria basically, in which we have to see that how much upper sling should be tightened and how much lower should be pulled, so that the conjunctival margin of the lower lid should exactly touch the globe. Okay. And of course, because we are doing in the local, so it is easier, because what I do, I inject xylocaine beforehand, so that at least disperse it thoroughly, so that almost normal anatomy we can see on the table.
So on the table, your end point is when both the lids are well opposed
Yeah,
to the
little over.
And you have to also mention you have taken care of the punctum and the...
I just want to ask, why not temporalis fascia instead of muscle? Because fascia is so elastic, it helps in a better lid closure. Why are you taking the muscle and not the fascia?
Actually, muscle has got the dynamicity, whereas fascia is not having its toughest touch, it's not having dynamicity. Before also the workout procedures before have been done, they also incurred the muscle only, not with the fascia. The fascia had been used just to lengthen the muscle, because muscle itself cannot come up to the medial canal.
No, but your elasticity would come from the silicone, right?
Yeah.
So she has a valid point that if you are getting the elasticity or the dynamicity from the silicone, then why do you need the muscle?
No, ma'am, because when we are achieving your during mastication procedure, then only muscle will move, not the fascia.
Yeah, the muscle only will.
Only muscle will move, not the fascia.
Are you saying that to ensure eyelid closure, the person has to keep moving the mouth?
You see, before I was using fascia data, and I have used in I think 40 cases roughly, because I was in Lada and a lot of leprosy patients used to come, and in those patients actually, after some time, they used to become spontaneous. But of course, sling, I doubt that this will become spontaneous at any point of time. But with fascia data, it used to become spontaneous with the time after 6 months or 1 year. So.
Okay, so you don't have a long follow-up?
No.
Just 1 minute. Because muscle always needs the artery to come with it. But the fascia, we don't need the artery since the air vessel. That's why I'm questioning you.
No, actually we are not
Otherwise,
dissecting.
this muscle will not stay because I also used to do
No,
Japanese
ma'am, just listen. Actually, we are not disconnecting the muscle from its belly. It is Jildos temporis has got the three wings, you know. So we are taking this wing which is going actually towards the ear, and that we have just misdirected.
Dr. Ramesh, that was an excellent video. How many of your cases had paralytic ectropia, or they didn't have any ectropia, along with the rhinoceros?
After surgery, so far before that, about I think 6-7 cases had ectropia, because his longest standing for physical is there. So in many cases you get ectropia.
So all of the cases got corrected. We need to do any other procedure for them?
No, it is corrected by this procedure only.
Okay, Ramesh, it's a very good concept and all that. You should just expand a little on it, and probably in our next OPI you'll have a talk exclusively of it, because people like us who have not seen this procedure, it will be very helpful.
Okay, thank you, sir. Thank you.
Yeah.
Doctor, are there any way for intraoperative mitomycin C in external acrocystal anastomy?
I'll be presenting effect of intraoperative mitomycin C in external DCR. We have no financial disclosures to make. External DCR is the gold standard surgery for NLD obstruction beyond common anatomy. The success of this surgery demands an adequate exposure of deeply seated sample, making a large ostium and a good flap anastomosis. Also, preventing closure of the osteotomy site. Numerous modifications have been done for better surgical outcome with all alternate basic concepts. Mitomycin C is an antineoplastic antibody that inhibits DNA, RNA, and protein synthesis. It suppresses fibrosis and vascular proliferation and has been used in various ocular surgeries like trabeculectomy and pterygium excision. Our aim is to study the effect of intraoperative mitomycin C in single and double flap DCR. We have done the prospective interventional study on 80 cases of primary acquired nasolacrimal duct obstruction. The patient above 20 years of age of primary acquired nasolacrimal duct obstruction with patent common canalicles were taken, while those with acute necrocystitis, secondary duct obstruction, failed DCR, nasal mucosal pathology, and bleeding disorders were excluded. Apart from the routine preoperative workup, we have done lacrimal irrigation, Jones diet test, and tear meniscus height in all these patients. They were randomly assigned in two groups. Group A operated with external DCR without use of mitomycin C, and B with external DCR with the use of mitomycin C. Half of the patient in each group underwent single flap and half underwent double flap DCR. Now coming to the surgical technique. In all patients, after making the skin incision and exposing the anterior lacrimal crest, we have made a bony ostium, and in group B, we have applied mitomycin C 0.2 mg per dl for 5 minutes over this osteotomy site. In half of the patient in group A1 and B1 who were operated with single flap, we have excised the posterior flap. In the rest of the patient, group A2 and B2, we have sutured the posterior flaps also. Anterior flaps were sutured in all the cases, and then the surgical wound was closed in layers. Follow-up visits were done in first, second, fourth week, 3 and 6 months, and post-operatively we evaluated patients for symptomatic relief. We did lacrimal irrigation and recorded Mount score. The surgical success in our study was defined by anatomical patency. The graph here shows the result, the demographic profile of the study group, where we can easily see the female outnumbered male patient, and the mean age of the study group was 41 years. There was no significant intraoperative complication in either these groups. The graph down shows the success rate in group A was 78% and in group B with the use of mitomycin C it was 90% and this difference was significant. While the graph here shows the patency and non-patency in single and double flap which were comparable, there was no significant difference. The pie chart showing the month score at the final follow-up of 6 months which were comparable with the patency of Lecramen medication. In present study, the overall success of external DCR was 84%. In literature, the reported success varies between 80 to 99% depending on the type of technique used for the surgery. The surgical failure is defined as having excessive symptom and inability to escape. One of the important causes is blockage of osteotomy opening by excessive tissue growth and scarring. Thus, if we can reduce the fibrous proliferation at this site, the success rate can be increased further. In present study, the patient treated with mitomycin C during DCR had significantly greater surgical success as compared to those in whom it was not used. The intraoperative topical use of mitomycin C reduces the scarring and prevents the occlusion. Several other studies have also reported similar results. Although there was no significant difference between the surgical outcome between patients operated with single flap or double flap DCR. So, in conclusion, we can say that although external DCR has high success rate, but some cases may show failure due to closure of osteotomy site. Soaking mitomycin C over the osteotomy site reduces adhesion and prevents subsequent closure. Thus, intraoperative mitomycin C application in external DCR improves the surgical outcome.
Thank you, doctor. Did you
It's also an important cause, and in the cases where mitomycin C was not used, there was definitely closure of the site. So common canalicular obstruction was found in both the groups.
So you should include that in your paper, that in the failure cases, because that's what's significant, right?
Yeah.
No, the failure cases, how many of them had osteotomy closure without mitomycin? So there you are proving that your mitomycin is working.
We should also mention the point. See, some of our cases I've seen closure of the osteotomy even after as late as 6 years, 7 years after the external DCR, excellent flap, 2 flap technique and all. So where was this mitomycin working 6 years down the line? So there are other causes like sinusitis, inflammation of the mucosa surrounding it, health of the nasal aspect, all those things I think all should consider. Actually say it's if you say there was CC block in both the groups, that means the CC block was missed in the initial period.
No. Initially we common canaliculus was patent. We have actually included only those patients.
Post-operatively, both the groups developed CC block?
Post-operatively, CC block has been reported as an important cause of failure.
No, forget the reporting. What happened in your case?
In our patient, it might be due to the post-operative inflammation and the
manipulation due to what?
Manipulation
due to what? Some sinusitis, some mucosal inflammation.
Maybe that, or maybe the routine cleaning process.
I don't think in DCR we can say I had manipulation problems due to which you developed inflammation.
Actually, the inflammation thing is depends on the patient's own.
No, it's okay. It's a good attempt, but some food for thought is there. In this, just work on it a little more.
Actually, we are working, but results are not out.
Because we should not depend on the east or the west. Our results are the most important. So please work on it.
And colleagues, my paper is on surgical management of essential blepharospasm, our experience and long-term results. I have no financial disclosure in this presentation. Benign essential blepharospasm, as we all know, is characterized by an involuntary forcible closure of the eyelids involving the orbicularis oculi and the upper facial muscles. Isolated spectrum of facial dystonia. It can be either isolated or in a spectrum of facial dystonia. It starts with excessive blinking and goes on to have a severe spasm precipitated by bright light, reading, driving, stress, and associated deformities due to this such as dermatochalasis, brown eyelid ptosis, dry eyes, and lower lid laxity. Pathophysiology is, there is no really identified cause. It is multifactorial in origin, but however it's based on a protractor-retractor activity inhibition theory, where they say the protractors of the eyes, which are the orbicularis, corrugata, and the procerus, overact, not allowing them to get relaxed, and hence the retractors are unable to come into play. So apraxia of lid opening is described as a non-paralytic inability to open the eyes at will, as is seen in this case in this lady, and the absence of visible contraction of the orbiculus oculi. It can either be a pure ALO, which is usually very rare, or commonly associated with BD in 7 to 10% of cases. These patients, in spite of having botulinum toxin, tend to have very high failure rates or respond in a few months and require an injection as early as 2 months. The management of BB is supportive in educating the patient, pharmacotherapy, chemical myectomy, then botulinum toxin, which is now considered the modality of choice, and surgery, which was facial nerve avulsion and surgical myectomy. In 1941, Fox tried a surgery where he removed the upper and the lower orbicularis, and the pretopstarsal orbicularis were left intact, and tried it for a case of blepharospasm but did not have very good results. This was taken up by Gilliam and Anderson in 1981, and a similar thing was done but using a brow incision but removing all the protractors. However, it developed significant complications in the form of lymphedema due to removal of the upper and the lower orbicularis. Further modified by Gilliam and Anderson again later, they divided into a limited and a full myectomy. Limited was only removal of the upper eyelid orbicularis, whereas a full myectomy through a blepharoplasty incision was removal of all the protractors of the upper eyelids. There is a recent paper in Current Opinions in 2013 which has very clearly now indicated the reason to do a surgical myectomy, in which Anderson is one of the people who's the author, in which he says ALO-associated BB, blepharospasm-associated deformities, unresponsive to botulinum toxin A, and unaffordability is one of the 4 main indications for a myectomy. The purpose of our study is to describe the technique, long-term results, and advantages of eyelid protractor myectomy as the surgical management of BB. It is a single-center retrospective interventional case series done from 2010 to 2013 at BD Hinduja National Hospital in Mumbai, using the eyelid protractor myectomy procedure by Gilliam and Anderson. So the procedure involves the patient was taken under general anesthesia, and the first upper eyelid creases were marked on both the sides. Following this, a solution known as Klein solution was injected in both the eyelids as is seen here. Klein solution is a combination of normal saline 500 ml, 0.5 cc's of adrenaline and 2 cc's of 2% lignosulfone with adrenaline. This is very popularly used by the plastic surgeons when they are about to harvest fat in liposuction areas. So this, as you can see, is giving this yellowish sallow appearance because of vasoconstriction and an anesthetic effect. Following this, an eyelid crease incision was made, and the palpable orbicularis oculi is exposed as is seen here and then is removed. Following this, the orbital part of the orbicularis oculi is separated, and you go up to the supraorbital rim and the lateral part and separate the entire orbicularis away from the skin and right up to the margin and remove it in toto. You can see here that the entire orbicularis oculi is removed, right, extending up to the lateral raphe, so as not to leave any muscles just to prevent the contraction, and the palpable orbicularis oculi is removed. Then the corrugators are identified and removed, and the procerus and the eyelid incision is closed as a blepharoplastic incision. Done 3 cases in which 2 were males, 1 was a female, and all of them had received prior injections of botulinum toxin. Only one patient, the lady, had an association with ALO and repeated failures with botulinum toxin in the form of early injections at almost every 2 months. The indications in this case, one patient was unaffordable. The second male patient had very, very severe vasovagal attacks, which actually were one of the main indications, and associated deformities. Post-operatively, we had no recurrences in the upper lid. We have not given any additional botulinum toxin. Only one patient had other procedures in the form of a browplasty. And however, 2 patients developed dry eye at 6 to 9 months, which resolved spontaneously. This is the post-operative result at 1 week and at 1 month. So this is the result showing the patient with a bilateral browplasty with an upper lid myectomy done with no residual low eyelid twitching and no Botox given, and the spontaneous resolution of his dry eye. As you can see, this is the same patient shown in the earlier video in the beginning. And as for this is the lady with the AIO, and she is also showing a complete resolution. She had a component of a mild BB with an ALO, and no Botox was given, and she has responded well. The pitfalls is it's a technically challenging surgery, and poorly done surgeries require Botox, which is difficult to administer due to scarring, and patients have supraorbital hyperesthesia. However, this is a permanent surgical treatment. Patients are able to lead better and more normal lives. Second, safe surgery for the deformities can be done without much morbidity, and lower lid twitching is not significantly bothersome. To conclude, apraxia of lid opening associated with BED is an indication for myectomy. A correctly done protractor myectomy is beneficial for a large number of patients, and this is a long-term study with a 2-year follow-up. Thank you.
That was a good presentation.
So usually we give around 20, I give 25 to 30 units per side of the eye, mostly going up to 25 units. And they at least last, even the severe ones, for about 3 to 4 months. We had the lady with the ALO who came back to us with the same concentration that I have been using.
No, is there any criteria you've adopted in your study, like giving a 3
No, the
injection, 4
criteria,
injection?
sorry. So the criteria that
Not
I
getting immunity to the
where it mentioned that ALO is unresponsive and that you have to give repeat Botox procedures which are closely within almost 4 to 6 weeks, some of the papers have mentioned. And in this really a very good landmark study which was done in Current Opinion recently, they have said that the ones with ALO will probably may not even last for up to 4 to 6 weeks, or some of them are completely unresponsive and will still continue to have the blepharospasm component will go, but the ALO component remains. So they don't really benefit from it. So that was my criteria.
In that male patient, photo below.
For the man, the above one was post-operative at 1 week where he had a bit of lag off, and the lower one was where he didn't have lag off.
He had very severe photophobia in that.
No, he's closed his eyes and I wanted to show the lag off thermos, so I asked him to take a closed eye picture.
Yeah, I want to know how much of lag off did you get, and
Yeah,
what about ptosis? Was there any immediate ptosis? No.
No. So a lot of times they advise for a blepharoplasty. I didn't do it for any of my patients, but maybe retrospectively I wouldn't mind doing it. I had measured the Schirmers pre-operatively. They were good Schirmers. The only thing that came up was that 2 of these patients, absolutely good Schirmers, I'm documenting. I have documented the Schirmers at every visit. And after 6 months, at 6 months, one developed a dry eye, and one at 9 months, which lasted for about 6 to 8 weeks and developed a bit of filaments. So the only thing we could think of when we went through the literature is that possibly because of the lag off or
Was
a
that
late
the
onset
male
that
patient with the dry eye and the filament?
both. Maybe that decreased
explains
blink.
that.
But in spite of putting on tear supplements, one fine day after a 6-week follow-up, it just disappeared. And then after that, it's been 2 years and they've not had it.
Try Celluvisc. I'm not advocating any company, but try something
We got the
strong.
cornea people also because we were very concerned why it was a late onset. But it just
Dr.
disappeared.
Sabri, have you tried any top-up Botox in your case after myomectomy?
No, I have not
I
tried
could see
that.
one case where still after myomectomy, the lower lid was still blinking, having the spasms.
So the gentleman has a little lower lid twitch, but he is considering what he was, he's absolutely not bothered about it. And the lady did not have much lower lid twitching, so she was. I have done 3 more cases after that. So I think maybe I'd be a little cautious because I'm choosing the really severe ones, but the ones who are counseled enough to let them know that they will have some amount of blepharospasm and that we're not going to completely remove it, but their quality of life will far improve where they're not retracting their eyelids and walking around.
Okay, thank you.
Orbital lesion and their association with systemic disorder. The purpose of this paper is to emphasize adequate evaluation and management of patients with the unusual presentation of orbital lesion and to establish their possible systemic association that will likely to play an important role in care of these patients. Now moving on to my first case. This is a 62-year-old female homemaker came to us with a complaint of painful recurrent swelling in the right nasal region since last 1 month. Systemically she was a known case of hyperthyroidism with vitiligo. Ophthalmic examination was done and vision was best corrective vision was 6/6 in both eyes with IOP within normal limits. On anterior segment evaluation, there was a tender nodular swelling in both the canaliculus. As a routine initial clinical diagnosis of canaliculitis was made, local medication was started, but it was refractory to the local medication. Proplas was negative and syringic was patent, and rest of the anterior segment was within normal limit. On posterior segment evaluation, she was a dissuspect and 360 degree with having 360 degree open angles with pachymetry within normal limits with Humphrey with visual fields within normal limits. So we draw suspicion and we did incision biopsy in which we found there are Langerhans types of giant cell were found with no necrosis and Montreux was negative, and serum A's were higher side, and PFT was 20%, showed 20% impairment, and X-ray chest showed bilateral hilar prominence. CT thorax also showed similar result like bilateral hilar and lymph nodes, and patient was sent to expert opinion from immunologist and pulmonologist, and she was diagnosed with sarcoid stage 1 with no parenchymal involvement, and management with immunosuppressant therapy with corticosteroid was initiated. Patient responded well to treatment and local resolution of swelling was there. She was systemically stable and moderate resolution of lung was there, and she was later started on methotrexate therapy. Literature-wise, if we see, sarcoidosis is a granulomatous multisystemic disease that affects lung, skin, lymph node, liver, spleen, heart, central vertebral and nervous system, musculoskeletal system, and salivary glands. Ocular involvement per se manifests in 25 to 60% of patients with systemic sarcoidosis. The most common ocular manifestation of sarcoidosis is uveitis, while orbital is dacroretinitis, which is frequently bilateral. Eye nodules in sarcoidosis are present in only 3% of the patient, and the most common manifestations are small papules, eruptions, large nodules, ulcerated nodules. While the localized, in our case, the localized eyelid involvement around both the canalicular seen is a presenting feature of sarcoidosis, which is an unreported finding. Next case is a diabetic patient, 57-year-old male diabetic patient. He was coming for frequently follow-up in our retina department, and already received 3 doses of intravitreal bevacizumab. But after giving 3 doses of bevacizumab, he started complaining of consecutive severe bilateral doses with diplopia and elevation, with right eye restriction on elevation, adduction and abduction. We did MRI orbit and lesion in bilateral superior recti was found, and intraorbital lesion on the lateral aspect of the right optic nerve, multiple intracranial metastatic foci, and hypointense lesion in the vault of the skull and the cervical vertebra were found. He was sent to general physician and PET scan was done, and what we found is there were metabolically active lesion in the both lobes of liver were there. Multiple osteoblastic metastasis was there, and there is a lesion, active lesion was there in lesser curvature of the stomach. Upper GI endoscopic biopsy was done, and diagnosis of gastric adenocarcinoma stage 4B was done. He was started on palliative chemotherapy, but patient died within 8 weeks of diagnosis. Metastatic tumor of the orbit account for 1 to 13% of all orbital tumors and 2 to 3% of all systemic cancer. GIT carcinoma with metastasis to the orbit represent approximately 6 to 7% of reported cases, and an estimate of 5% of orbital metastasis involve only extraocular muscle. Third case, this is a 44-year-old male came to us with a complaint of painless mass, recurrent mass growing over conjunctiva since last 2 years. History of multiple consultation and cryotherapy was there. Vision.
Go only to the salient point quickly.
Rest of the things were now treated. Conjunctival biopsy was done, and on the histopathological examination, conjunctival amyloidosis was found, which was confirmed on the IFC, and systemic evaluation was done, but there was only grade 1 prostatomegaly, and MRI scan showing of the same patient. Patient was advised both had debulking followed by chemotherapy, but unfortunately patient was outstationed, so he is taking treatment there only. There are 3 major types of amyloidosis primary.
Please keep this.
Okay. Another case, a 40-year-old male came with blurred vision in the right eye since last 4 months. He is a diagnosed case of subclinical hypothyroidism. As per old reports, he was getting treated for primary open-angle glaucoma elsewhere, and was taking treatment for the same. These are the visual field scan. In the right eye, we can show.
Next.
Humphrey visual inferior defect, and mild axial proptosis of the right eye was there with marginally elevated TSH. MRI showed right sphenoid wing meningioma with intracranial optic chiasmal involvement. This is a magnified picture of the MRI scan, and patient underwent craniotomy with excision of the tumor. Histology of the excision showed meningothelial meningioma of grade 1. Vision was better, IOP was fine, and take-home messages for careful history, thorough local and systemic evaluation, and we should not hesitate for second opinion in these kind of patient, multi-modality approach is beneficial.
See, the take-home message is, if you have a conjunctival lesion, you think first only of a SCORM paper.
Yes.
And I was very happy to see take-home message, but below that we all know this. Even the first year MBBS will know this. But you want, if you see a lesion like this, just don't think it's a glaucoma. Look behind. No? We're learning, we're all learning, okay? I'm not trying to criticize, it's a great paper. But this is what is the take-home message. So don't think every conjunctival lesion, if not a Salmon path, is only a carcinoma. Amyloid is a very common because of so many immune factors, right? Good, very good.
The next paper is by Dr. Bhargavi Pawar, and she's going to present a paper on, it's to report a rare ocular manifestation of sickle cell anemia.
Good morning, everybody. Today, early last year, so we have no financial interest in any of the subject matter. To refresh our memory on sickle cell disease, it is a structurally abnormal hemoglobin HbS mutation which causes a sickling of RBCs when they are exposed to any drop in arterial saturation or predisposing factors like fever, infection, or exercise and increase in temperature. A crisis may be defined as an ischemic episode due to infarctions of musculoskeletal tissue and vital organs, characterized by pain, fever, tachycardia, and anxiety. The demography of sickle cell disease in India. Most commonly, it is seen in people of African, Mediterranean, Indian, and Middle East origin. But it does represent a significant public health problem in India. India, in fact, is home to 50% of the world's sickle cell patients. They are mostly seen in the socio-economically disadvantaged sects of the SC, ST, OBC, and central India, especially regions of Madhya Pradesh, eastern Gujarat, Chhattisgarh, and Orissa, has a prevalence rate of almost 9.4%. Pockets are also seen in Assam and central Tamil Nadu. The ocular manifestations that we are familiar with include neovascularization of the retina and disc, leading eventually to tractional retinal detachment. A classic CFAN appearance also appears on FA. But how common are orbital manifestations? So far, only 5 to 6 cases have been reported in literature. We had a 23-year-old African male who was a known case of sickle cell anemia who presented to hematology with acute onset of fever, abdominal pain, and severe arthralgia. He was diagnosed to have a crisis. On the second day of treatment, he developed ptosis and limitations of ocular movement in the left eye. Clinical examination showed the vision was 6/6 bilaterally. The left eye had mild proptosis, severe ptosis, periorbital edema, and a pale type of chemosis. The pupillary reaction was normal. Fundoscopy was also normal. The extraocular movements in the right eye were normal, whereas in the left eye there was limitation of movement in all directions of gaze. There was a mild rise in temperature locally while palpating the lids. So we made a provisional clinical diagnosis of painful external ophthalmoplegia with proptosis in the left eye. Now, was this a case of orbital infarction, or was it a case of orbital cellulitis, knowing that sickle cell anemia patients are very prone to gram-positive cocci infection? We got a CT done, and since it wasn't conclusive, we went further and got an MRI done. The CT showed left orbital proptosis with preseptal cellulitis. The MRI showed preseptal edema with minimal fat stranding, but there were no collections in the orbit to explain the proptosis. The CT said it was preseptal cellulitis. So we had a diagnostic dilemma. Clinically, there was no sign of inflammation, although radiologically it suggested otherwise. If indeed it was a vaso-occlusive crisis, could there be orbital ischemia without affecting the retinal or the choroidal circulation? And the clinical signs of proptosis, lid edema, and pale chemosis with painful ophthalmoplegia, where did it fit in? So he was managed conservatively by hematology with packed cell transfusion, morphine, and IV fluids. From ophthalmology, we just gave him broad-spectrum antibiotics and gave him ecosprin suspecting infarct. So on day 1, this was his picture, but there was a dramatic improvement by day 4. Ptosis had improved, movements almost returned to normal, and the proptosis also had reduced. So we researched and we found that bone infarction is a common occurrence in sickle cell disease. Patients who have bone infarction can present with frontal headaches, proptosis, ophthalmoplegia, and lid edema. Infarcted bone generates an inflammatory response. In fact, there are 2 types of responses of infarcted bone. One is an inflammatory response, which can explain the orbital pain, the proptosis, and the chemosis. The other thing that a bone infarction leads to is a vessel wall necrosis adjacent to the infarcted bone. This causes a bleed, a collection in the orbit, a hematoma, which in turn can lead to proptosis, optic nerve compression, and orbital compartment syndrome. As far as choice of investigation goes, CT has its limitations because it can diagnose mostly soft tissue swelling, but not the nature of the collection. MRI, on the other hand, can detect marrow ischemia to some extent, but can differentiate an abscess from a hematoma, but not really differentiate an infection from an infarction. Whereas radionuclide scanning or scintigraphy is confirmatory because of the decreased uptake of nuclei in infarcted bone, and hence is confirmatory for bone infarction. So the highlights of what I'd like to make is that sickle cell disease is in fact a public health concern in India. Atypical presentations such as these, like orbital infarction and ophthalmoplegia, can occur, though we are more familiar with the retinal involvement. The importance of clinical correlation, especially when there is a conflict between radiological and clinical diagnosis, and selection of the appropriate investigation, whether it's CT, MRI, MRA, color Doppler sonography, or scintigraphy, scintigraphy being the best if available, and sickle cell crisis with orbital involvement should be treated as a medical emergency because it can lead to orbital compartment syndrome, leading to optic nerve compression and eventually CRAO. We also would like to state that although this was an African national, it prompted us to research and find out that the prevalence of sickle cell disease is in fact higher than we anticipate in India, and we should be prepared for eventualities where they present with orbital manifestations such as these. Thank you.
And infarction.
That's right, ma'am.
We can't really, and we didn't do the scintigraphy. So this is in retrospect, you feel that it was an infarction and not an infection.
Yes, that's right. We in fact gave empirically, are prone to pneumococcal infections. We said let's give it a shot, but there was no congestion. There was a very minimal pain.
Could it be that the sickle cell crisis modified the signs of inflammation? Is that a possibility? And
probably the signs of inflammation.
That's why we didn't get congestion chemosis like you would expect in an orbital cellulitis.
Yes, ma'am. But then, if there had been an infarct, why did it not really, affect the other parts of the eye? If it was exclusively an orbital infarct, which was not allowing the signs of inflammation to manifest, why was the retina and choroid spared? This is something that we could not explain.
As a compartment syndrome, and that's why the retinal and the choroidal vasculature was.
That was in retrospect. That was in retrospect, but we initially suspected the small vessels of the orbit to have been infarcted, and therefore the pallid chemosis that presented itself.
But then it should not be reversible. How do we explain it if it
once
was
there is recanalization, probably it could have been reversed.
And blood culture? Did a blood culture show any?
No, a blood culture was negative.
Very beautifully presented, but first point was, why do you say it's a crisis in India, a public health issue in India?
Because 50%...
What is exact, just one point as to why do you think it's a public health issue in India?
Ma'am, this is based on a thesis that was presented at University of Pittsburgh in 2013, which stated that 50% of this world sickle cell patients are in India, but the reason they don't manifest is that we have a genetic haplotype of the beta gene and the prevalence of thalassemia, which prevents a crisis from occurring, though sickle cell disease is prevalent here.
Any follow-up of the patients after the mission or discharge?
No, sir. He was an African national. He went back to his country. We could not follow him up, but we just thought it would be of interest to present him.
Radiology diagnosis and treatment of orbital mass.
I have no financial disclosures to make. The main aim of presenting this case is to highlight a new technique for management of an orbital vascular mass. Like we know, hemangiomas are benign congenital tumors comprising of proliferating endothelium. They are common in infants with an incidence of 3 to 12%. Angiographic guided sclerotherapy in the treatment of a vascular orbital mass is still in its primitive stage, but its use in treatment of lymphangioma is still known. Here is a case of a 6-year-old male who presented to us